I want to tell you about a man named Henry. Robert was 71 years old, retired engineer, sharp mind. He could still recite the specs of every bridge he'd ever designed, sometimes at the dinner table, whether his family wanted to hear it or not. Then, about a year after his doctor added 2 new prescriptions to his daily routine, his wife noticed something. Robert started repeating himself. He'd walk into a room and forget why he was there. He lost his train of thought mid-sentence, something that had never happened to him before. His family was worried. His doctor ordered a memory evaluation. The word early dementia entered the conversation. But here's what nobody had thought to check. Robert was taking 5 medications. 3 of them, belong to a drug class that quietly works against the aging brain. And not one person had sat down with Robert and explained that risk. When his physician, with the help of a clinical pharmacist, reviewed everything he was taking and made careful, supervised changes, Robert started coming back. Within 6 months, he was at the dinner table again talking about bridge engineering. His family called it a miracle. It wasn't a miracle. It was a medication review. And today, I'm going to walk you through the 9 most common types of medications that can quietly affect memory and cognition in adults over 60, so that you and your doctor can have the right conversation before a problem develops. My name is Henry, and this channel is dedicated to one thing: giving adults over 55 honest, clear, practical health information in plain language. Before we go any further, I want to say something important. Please do not stop or change any medication on your own after watching this video. Every medication on this list is prescribed for real reasons. Stopping suddenly, especially with some of these, can be dangerous. What I am giving you today is knowledge. Knowledge to ask better questions. Knowledge to have a more informed conversation with your doctor or pharmacist. That conversation could genuinely change your life. Now, if you're new here, please subscribe and hit the bell. I cover senior health topics every week in exactly this format: practical, honest, and always evidence-based. Let's get into it. Before we go through the list, I want to give you one concept, because without it, the rest of this video won't fully make sense. Your brain at 60, 65, 70 is not the same as your brain at 40, not because it's broken, but because it's running on a leaner system. One of the most important brain chemicals involved in memory and learning is called acetylcholine. Think of it as your brain's main messenger for concentration, recall, and clear thinking. In your younger years, your brain produced plenty of it. After 60, baseline acetylcholine levels naturally decline. This matters because a whole family of medications, called anticholinergics, work by blocking acetylcholine. In younger adults, the brain has enough reserve that the effect is mild. In adults over 60 who are already running lower, that same medication can have a much more significant impact. And here's the second factor. After 60, your kidneys and liver, the organs that process and clear medications from your body, work more slowly. Drugs stay in your system longer. They accumulate. An amount that was well tolerated at 50 may be too much at 70. Keep both of those ideas in your mind as we go through each medication. And one more thing, stay with me all the way to number 1, because number 1 isn't a single medication. It's a hidden pattern that affects millions of seniors, and it's the most important thing I'll say today. Let me ask you something. Do you have a bottle of something labeled PM or nighttime or sleep formula anywhere in your home right now? If you do, there's a very good chance it contains an ingredient called diphenhydramine, the active component in Benadryl, Zizquil, Unisum, and dozens of other over-the-counter products. It's inexpensive, it's everywhere, and most people think of it as completely harmless because you can buy it without a prescription. Here's what's actually happening when an adult over 60 takes it regularly. Diphenhydramine is one of the most potent anticholinergic substances available over the counter. Every dose directly suppresses acetylcholine, your brain's memory messenger, for hours. In a 2018 study published in the Journal of the American Geriatric Society, older adults who used diphenhydramine regularly showed measurably reduced activity in memory-related brain regions on neuroimaging. The tricky part, it hides. Check the ingredient list on any product labeled PM, pain reliever PM, allergy PM, nighttime cold formula. Diphenhydramine is almost always there. What to do instead? For allergies, ask your doctor about second-generation antihistamines, loratadine, Claritin, or cetirizine, Zyrtec, which work differently and have a much better cognitive safety profile. For sleep, we'll come back to safer options a little later. Overactive bladder is a real issue for many adults over 60. It's disruptive, it's embarrassing, and it absolutely affects quality of life. So when a doctor offers a prescription to help, most people take it gratefully. The most commonly prescribed medication in this category is oxybutynin, sold under the brand name Ditropan. Here's what most people are never told. Oxybutynin is one of the strongest anticholinergic medications still in widespread clinical use. It crosses into the brain with remarkable ease, and once there, it directly interferes with the acetylcholine systems responsible for memory and learning. A 2019 study in the British Medical Journal, tracking over 280,000 patients, found that adults who use strong anticholinergic medications, oxybutynin being among the most common, for more than 1 year had a significantly elevated risk of dementia diagnosis compared to non-users. The reason this goes unnoticed for so long, the early cognitive effects, forgetting appointments, misplacing objects, feeling foggy, are almost universally attributed to just getting older. The medication is never questioned. What to do instead? Ask your urologist or primary care physician about mirabegron, Myrbetriq. It works through a completely different mechanism, beta-3 adrenergic agonism, and carries dramatically less cognitive risk. It's worth the conversation. If you're finding this helpful so far, drop the number 8 in the comments. I read them all, and it helps me know who's watching and what topics matter to this community. I want to be careful here because many people have a deep personal relationship with this medication category, and understandably so. Benzodiazepines, Xanax, Ativan, Valium, Klonopin have helped millions of people through severe anxiety, panic attacks, and sleepless nights. For many, they felt like a lifeline during an unbearable time. I'm not here to dismiss that. What I am asking you to do is hear the long-term picture. Benzodiazepines work by amplifying a brain signal called GABA, your natural calm-down chemical. In the short term, they're remarkably effective. The problem emerges when that mechanism stays switched on for months or years. When GABA is chronically amplified, the brain gradually reduces its own natural activity in response. Neuroplasticity, the brain's ability to form new connections, learn and adapt, begins to slow. Memory encoding becomes less efficient. Over time, a 2022 analysis tracking over 8,000 seniors found that those on benzodiazepines for more than 3 months had a 51% elevated risk of Alzheimer's disease. Critical warning: never stop benzodiazepines abruptly. Withdrawal can be medically dangerous. Rebound anxiety and seizures are real risks. Any reduction must happen slowly, with physician supervision, over weeks or months. What to ask your doctor: whether cognitive behavioral therapy for insomnia, CBT-I, or non-benzo anxiety alternatives like buspirone might offer a safer path forward for you. This next one surprises people because it isn't on most lists, but prescriptions for gabapentin have increased dramatically over the past decade, and it's now one of the most commonly prescribed medications in adults over 60 for nerve pain, restless legs, and sleep. Gabapentin works by calming overactive nerve signals. For genuine nerve pain, it can provide real relief. The concern isn't whether it works, it's the cognitive side effects that often go unmentioned. Gabapentin affects GABA-related pathways in the brain and can cause significant cognitive blunting. Difficulty concentrating, slowed processing, word-finding problems, and brain fog. These effects are dose-dependent and tend to worsen over time, especially in older adults who clear the drug more slowly from their system. A 2020 review in Drugs and Aging noted that sedation and cognitive impairment are among the most underreported adverse effects of gabapentin in geriatric populations, partly because patients assume the symptoms are just aging, and partly because the connection to a medication taken for a completely different reason is rarely made. What to discuss: ask your doctor whether your current dose is still appropriate, whether a lower dose might provide similar relief with less cognitive impact, or whether non-pharmacological approaches, physical therapy, specific nerve blocks, topical treatments, could reduce your reliance on it. Raise your hand, figuratively, if you take an acid reflux or heartburn pill every single morning and you've been doing it for years without anyone ever suggesting you try to stop. Proton pump inhibitors, omeprazole, pantoprazole, esomeprazole are among the most prescribed medications in the world. They reduce stomach acid effectively. For short-term use, they're generally appropriate. The problem is that most people end up on them indefinitely when most PPEs were designed for 8 to 12 weeks of use. Here's why this matters for your brain. Stomach acid plays a critical role in absorbing vitamin B12 from food. B12 is not optional for brain health, it's essential. It supports the myelin sheath that protects your nerve fibers and is directly linked to memory and cognition. Long-term PPI use significantly reduces your ability to absorb it. B12 deficiency produces symptoms: memory problems, fatigue, difficulty concentrating, mood changes that so closely resemble early cognitive decline that the two are sometimes confused even by experienced physicians. A large study in JAMA Neurology found that long-term PPI users had a meaningfully elevated risk of dementia compared to non-users. What to do? If you've been on a PPI for more than a year, ask your doctor to check your B12 and magnesium levels. Discuss whether a supervised taper using H2 blockers, like famotidine as a bridge, is appropriate. Dietary changes, smaller meals, avoiding late-night eating, can help reduce reflux naturally. If this is hitting close to home, type the number 5 in the comments. Let me know you're here. Poor sleep is one of the most common complaints in adults over 60. And when a doctor prescribes a sleep medication, it feels like a reasonable answer to a real problem. The Z drugs, zolpidem, Ambien, azopiclone, Lunesta, are the most commonly prescribed. They work quickly, they produce sleep, and they seem to help in the short term. But here's what the research shows with long-term use. Z-drugs work through similar mechanisms to benzodiazepines, suppressing the brain's natural activity to induce sedation. With extended use, they interfere with sleep architecture, specifically the deep and REM sleep stages, where the brain consolidates memories and clears metabolic waste products, including amyloid, the protein linked to Alzheimer's disease. In effect, you may be sleeping, but your brain isn't doing the nighttime maintenance work that protects it long term. The FDA updated its safety labeling for these medications in 2019, noting risks of complex sleep behaviors and next-day cognitive impairment, particularly in older adults. What works better? CBTI, cognitive behavioral therapy for insomnia, has been shown in multiple studies to outperform sleep medication for long-term outcomes. It addresses the underlying patterns driving poor sleep rather than suppressing them. Ask your doctor for a referral or for a CBTI app approved for clinical use. This one catches people off guard because it's often used short-term for a pulled back, a stiff neck, a muscle spasm after a difficult week. Nobody thinks of a muscle relaxant as a brain medication, but cyclobenzaprine, Flexeril, one of the most commonly prescribed muscle relaxants, is strongly anticholinergic, and in adults over 60, its effects are significantly amplified. The American Geriatric Society has placed cyclobenzaprine on its Beers criteria, an official list of medications considered potentially inappropriate for older adults, specifically because of its anticholinergic burden and the elevated risk of confusion, sedation, and falls. Many seniors take it for a few days, notice some grogginess and mental cloudiness, assume it's just a side effect they have to tolerate, and don't think to connect it to anything deeper. When taken repeatedly over months, the cumulative effect on acetylcholine levels becomes clinically meaningful. What to discuss? Ask your doctor whether physical therapy, topical anti-inflammatory treatments, or heat/cold therapy might address your muscle pain without the systemic cognitive risk. If a muscle relaxant is truly needed, methocarbamol carries somewhat lower anticholinergic activity. Here's one that very few people know about. Hydroxyzine, sold under the brand names Vistaril and Atarax, is an antihistamine that's increasingly being prescribed for anxiety, particularly in adults who want to avoid benzodiazepines. On the surface, that logic makes sense. It's non-addictive. It's not a controlled substance. Doctors often present it as a safer alternative. What isn't always communicated, hydroxyzine is a first-generation antihistamine, meaning it crosses the blood-brain barrier readily and has significant anticholinergic activity. It directly suppresses acetylcholine in much the same way as diphenhydramine or oxybutynin. For short-term situational anxiety, a single dose may be appropriate. As a daily or frequent medication in adults over 60, the cumulative anticholinergic burden is real and warrants attention. It also appears on the Beers criteria for adults over 65. What to ask? If you're on hydroxyzine for anxiety, discuss with your doctor whether buspirone, which works through a completely different mechanism with no anticholinergic activity, might be a better long-term option. It's less immediately calming, but it builds over weeks without the cognitive risks. I told you at the start of this video that number one wouldn't be a single medication. Here's why. Every medication we've discussed today carries its own anticholinergic burden, its own degree of impact on your brain's acetylcholine levels. Taken alone, some produce only mild, barely noticeable effects in some people, easy to dismiss easy to attribute to age. But here's what happens in the real world. The average American over 65 takes 4 or more prescription medications daily. Many take 6, 8, or 10, prescribed by different specialists who may not have full visibility into what else is on the list. Add in over-the-counter products, and the picture gets even more complex. When several of those medications carry anticholinergic properties, they don't simply add to each other's effect. Research suggests the combined impact can multiply. A 2022 analysis published in Age and Aging, tracking over 280,000 older adults, found that those with the highest anticholinergic burden had a 120% increased risk of developing dementia over a 10-year period, double the normal risk, from pills that most of them had never once been warned about in terms of cognitive risk. Imagine a 68-year-old woman, let's call her Carol. She takes a PM pain reliever at night to sleep. She takes oxybutynin for bladder control. She takes hydroxyzine for anxiety. And she takes an over-the-counter antihistamine for seasonal allergies. 3 or 4 of those are anticholinergic. Each one, according to her separate prescribers, is appropriate. Together, her anticholinergic burden score may be in a range clinically associated with significant dementia risk, and not one doctor or pharmacist has done that math. This is not a hypothetical. This is happening in households everywhere right now. The medical term is anticholinergic polypharmacy, and it may be the single most underreported driver of dementia-like symptoms in older adults today. The crucial truth, drug-induced cognitive decline is often reversible. When the medication burden is identified and carefully reduced under proper medical supervision, many patients experience a remarkable recovery of mental clarity. The fog lifts, the person comes back. Your brain is not a passive organ. It is adaptive, resilient, and capable of significant recovery when given the right conditions. Here is exactly what I want you to do with this information. 5 concrete steps. Start this week. Step 1. Write down every single thing you take, every prescription medication. Every over-the-counter product, every supplement, sleep aid, and allergy pill. Don't leave anything out. Step 2. Look up each item on the Anticholinergic Cognitive Burden Scale, the ACB scale. It's a free, publicly available tool. Search ACB scale medication list and you'll find it. It scores each medication by its anticholinergic risk. Add up your score. Step 3. Schedule a medication review with your primary care physician. Use those exact words. I'd like to schedule a medication review to look at my anticholinergic burden. A good physician will not be offended. They'll appreciate your advocacy. Step 4. Ask specifically about deprescribing, the intentional supervised process of tapering off medications that are no longer needed or that carry unacceptable long-term risk. It's a growing and legitimate field in geriatric medicine. Step 5. If you'd like a more thorough evaluation, ask about seeing a geriatric pharmacist. Yes, that specialization exists. They perform comprehensive medication reviews specifically for older adults and can identify risks that a standard appointment might miss. I want to leave you with something that I think matters more than any individual medication on this list. The cognitive decline that gets prevented doesn't feel dramatic. There's no moment where you are aware that your clarity was saved. There's just an ordinary Tuesday, a conversation with your grandchild that flows easily, a book you finish and remember, a decision you make with confidence. That ordinary Tuesday is what this is protecting. Write down the medications we covered today. Share this video with someone over 60 who might benefit from seeing it, because the person who most needs this information probably isn't searching for it themselves. And if any part of what we discussed today matches what you or someone you love is experiencing, don't let another week pass without bringing it up with the doctor or pharmacist. Thank you for spending this time with me today. Your brain is extraordinary and it deserves to be protected. I'm Henry, and this is WellAge Health. If this video gave you something useful, please subscribe, leave a comment below, and tell me, which of these 9 surprised you most? That helps me understand what to cover next, and it helps this information reach more people who need it. Stay strong, stay wise, and I'll see you in the next one.